start this session about multiple myeloma, and I am honored to introduce Hans Lee, which is my co-chair and is one of the responsible for multiple myeloma and plasma cell dyscrasias in MD Anderson Cancer Center, and it's a pleasure for us to have his experience with us.
So first, we're going to have Dr. Certrioni speak about multiple myeloma, state-of-the-art in Italy.
So, multiple myeloma panorama is completely changed in last years. And in particular, since 2003, we have seen many novel agents starting from bortezomib, which has totally changed the prognosis, the results in multiple myeloma, going until monoclonal antibodies, and we are going towards the era of CAR-T treatment and vaccines, and maybe also of nivolumab and atezolizumab. Natural history remained the same. Myeloma today is a treatable but not curable disease. We often start from an asymptomatic phase in which we have MGUS or smoldering myeloma, and Hans will speak also about smoldering, which they have very interesting new approaches. Active myeloma start to be symptomatic. We give a first-line therapy with a plateau remission, today longer in many cases, but in one moment we are going towards a relapse. Relapse in which we have many second-line approach, new plateau, not so good as the first one, going to second relapse, until a refractory relapsed multiple myeloma after n line of treatment. Survival of multiple myeloma was, before 90, 17 months before the chemotherapy era. ESMO guidelines give like an order in the diagnostic, biologic approach, imaging, and monitoring of multiple myeloma. And in particular, they introduce the importance of minimal residual disease, which should be, in particular in frontline treatment, one of our goals of treatment. When we are in front of a newly diagnosed multiple myeloma, the first thing to consider is the eligibility for autologous transplantation. And in particular, if the patient is eligible, there are 3 drugs regimen. And in particular, in Europe, bortezomib-based regimen, in which VTD has shown a superiority to the other bortezomib-based. The number of induction is usually 4. We in Italy usually perform 4 regimen, and then we go towards the following parts of the treatment. Our goals are to maximize the rate and depth of response, to minimize residual tumor cells beyond the level of MRD negativity, which is our aim in this moment, to prevent and delay relapse, to increase progression-free survival and overall for survival is our secondary goal, it's normal, and tailored treatment is going to be reality. After induction regimen, conditioning with melphalan and then autologous. In Italy, for Italian school, we usually perform 2 autologous, even if data are discording if we consider some European studies, but ESMO guidelines consider the best results of second autologous in frontline treatment in high-risk categories. So it is the best to do, and we prefer to perform in every patient if they consent. This is VRD and autologous, but in Italy we can't do VRD regimen. And the consolidation is another new approach. Usually we can do, also in Italy, 2 VTD cycles after autologous in order to consolidate the very good response we have obtained, but also in this case data are again discording at the moment. Lenalidomide maintenance is the new part of Italian and European approach. We know that data about progression-free survival after 7 years, so we have a very long follow-up. Data of progression-free survival and overall survival are more than good. We think that now is the standard of care, and it's absolutely part of frontline treatment in every transplant-eligible multiple myeloma. How to choose the regimen in transplant-ineligible patient? We have 2 possibilities. We have a bortezomib-based approach, which is VMP, which is a fixed duration, versus continuous treatment with RD. So the possibility is to decide also considering not only the better result, but we want the best compliance in this subset of patients. It depends by logistics, by the availability of caregivers, which are really important to be considered in these patients, which are often old, but also sometimes they have very great difficulty to come in the institutions to perform a treatment with the hospital infusion, outpatient infusion. VISTA trial, we know the data. BMP has a superiority, statistical superiority to MP approach with a progression-free survival on 24 months and an overall survival with a statistical significance. This is the present of transplant-ineligible multiple myeloma approach. This is the near future. Alcione trial is maybe a dream which we can realize in transplant-ineligible multiple myeloma. Data are excellent. With a median follow-up on 28 months, we have a median of progression-free survival of 19 months, and it's arriving also in Italy. We hope really soon. But the great data is the overall response rate. 91 overall response rate with 22% of stringent complete CR is really a new data in this category of patients. And moreover, we have solid data also about the MRD NGS monitoring. The eligibility of transplant, the transplant ineligible, we have also another possibility, which is very good, which is often used in Italy, RD continuous treatment. RD continuous treatment, we have seen the superiority to RD 18 cycles and to MPT. So now is the standard of care in patients which we want a therapy with a very good compliance, with the domestic administration, and we know that data are absolutely excellent, considering progression-free survival, considering overall survival, and time to next treatment. What is the near future of ineligible autologous patients? We have VRD versus RD, the SWOG study, which has shown for sure a statistical difference which we hope to have soon, VRD possibility also in Italy. Maya study is another great opportunity that we hope to have soon. Daratumumab, monoclonal antibodies in frontline treatment has shown a very great statistical difference, 31.2 months in RD arm. This has a significance. In control arm, we have seen that maybe we improve our approach to multiple myeloma, because if we compare the control arm of previous study, we had no so good result with RD treatment. These are the frontline treatment approved nowadays in Europe for multiple myeloma. So we can see bortezomib-based regimen. The first trial we have seen lenalidomide dexamethasone in continuous treatment, and these are the most used approach. The last three of them have a continuous treatment approach. Which are the open questions in frontline treatment? Double versus single, autologous, role of consolidation treatment, maintenance, maybe at the moment we have a certain lenalidomide maintenance, and the tailored risk-based treatment is the near future. About relapsed refractory multiple myeloma, I was curious to look at 2015, when we had only 2 opportunities in first relapse, and in particular we had lenalidomide dexamethasone versus bortezomib dexamethasone. Then in second relapse, we could use also pomalidomide dexamethasone, which was the newest approach, but we can see the overall response rate of them, and in particular that POMDEXA showed a median progression-free survival of 4 months versus 2 months of high-dose dexamethasone. What is today? Today we can differentiate at first relapse regimen after bortezomib-based treatment in front line and after lenalidomide-based regimen. We have many opportunities, many new drugs that we will see in the following slides. At the second relapse, we can use also pomalidomide, daratumumab as single agents, and clinical trials when we can. These are data of progression-free survival. We know that monoclonal antibodies are changing the history, the natural history of relapsed refractory multiple myeloma, but also carfilzomib is a very great weapon that we have available in Europe. What can we choose? At first relapse, we have RD, for domestic approach for patients who lack of caregivers, as we've seen before, and triplets. Triplets in after bortezomib-based induction can be lenalidomide-based as backbone of the treatment. And in particular, we have the possibility to use DARA-RD. We know the Pollux trial with very good results and very solid results with an overall response rate of 93%. KRD approach, the Aspire trial, we know that showed was the first approved in Italy treatment for relapsed refractory multiple myeloma, and we know that 26 months of progression-free survival is an impressive data for this subset of patients if we consider what we had before this. Tourmaline is the last approach that we have available. Ixazomib has received reimbursement and approval in this year. This is a good opportunity if we consider that this is the first domestic triplet. So in some categories of patients is useful. In Italy, I remember that has the approval in second relapse. For first relapse, only in high-risk category patients. 20 months of progression-free survival for a domestic approach is also really good. Eloquent trial was another immunotherapy approach. We have seen that in patients who show a good response, this response is like maintained during the years, and in particular it seems to reach a plateau going towards 4 or 5 years of follow-up, and it was approved 2 years ago in Italy. In first relapse after lenalidomide-based induction, maybe we have a problem, in particular in Italy. This, in my opinion, is an unmet clinical need. And in particular, we have available 2 opportunities. Carfilzomib, dexamethasone, endeavor studies, which has a statistical difference versus bortezomib-based, but it's not what we want. 18 of progression-free survival, maybe in a patient who is young, who can be fit, is not the best. The other opportunity is Castor trial, daratumumab, bortezomib, dexamethasone, which is good, but not so good as lenalidomide-based daratumumab approach. We know that also the overall response rate is a little bit lower. The study is different, they can't be properly compared, but I think we need something more. Maybe pomalidomide-based and carfilzomib-based triplets could be game changers in this panorama. And in particular, we are waiting for isatuximab, for daratumumab pomdexa, which we will see from monthly is showing very good results in United States. And Candor is our DIM, daratumumab, carfilzomib, dexamethasone approach, maybe is the best that we could consider today if we know the drugs we have available. Pomalidomide, bortezomib, dexamethasone is the near future. The approval is arriving also for Italy, and maybe this is particularly interesting also for compliance and efficacy. At second or subsequent relapse in this subset of patients, we have also pomalidomide, dexamethasone, as we have seen, and we have daratumumab single agents. Data of daratumumab alone are absolutely not good, in my opinion, in a transplant-eligible patients. As we can see from Gene and Sirius trials, the progression-free survival are poor. We need something more. Maybe it's not the best to use daratumumab alone. Maybe maintenance it will have a role, but not as a single agent in a patient in which we want to give a treatment and not a palliation. These are data of overall response rate. 30% of overall response rate is not good, 2% of complete response. Maybe the categories, the characteristics of patients of the studies are not so good, are not comparable with the other trials, the other registration trial, but we need something more. And this subset of patients, maybe clinical trials, is the best that we can do today. In conclusion, if we consider induction therapy, we have to select between eligible patient versus not eligible. In the first ones, we prefer a bortezomib-based, which is the standard of care also in Italy. Not eligible patient to autologous, VMP versus RD, considered fixed duration versus continuous control of disease. Autologous, upfront autologous remains the gold standard in eligible patients, also in the era of novel agents, and in particular double autologous improves progression-free survival and overall survival if compared with single autologous, in particular in high-risk cytogenetics patient. consolidation therapy maybe should be performed in all patients, considering that this is safe, this not add side effects, and maybe improves the response we have performed in frontline treatment. Maintenance with the lenalidomide should be performed in all eligible and fit patients, and is the only EMA-approved maintenance at the moment in Europe. In relapsed refractory, we have seen the efficacy and safety and novel agents-based regimens. Lenalidomide refractory in first relapse, in particular patients, represent unmet clinical need at the moment. Maybe pomalidomide-based triplets will solve this problem, but we don't know, and we don't know when we will have those in Italy and in Europe. So history has changed. This is the question with which I want to close my talk. Yes, history has changed for sure, but it's changing more and more. And if we listen to Hans Lee, the history maybe is changing in the near future. We hope so. Thank you for the attention. Thank you to everyone.
Thank you, Claudio, for that wonderful talk. Are there any questions? I think we have time for maybe one question, if anyone has a question. If not, I think we're want to stay on time, so I'll go ahead and proceed
Perfect.
on.
So I invite Hans Lee to present the state of the art in MD Anderson Cancer Center through SOHO approach, and we are happy to listen also to our near future, because we will have the approval of the same regimens in the next future. Thank you, Hans.
Great. So thank you so much for the invitation to speak at the first annual SOHO Italy meeting. And so today I'm going to provide a high-level overview of our treatment approach for multiple myeloma, with some particular focus on how we do things at MD Anderson, but also focus on a number of unmet, sort of unanswered questions that we need to answer to take the field to the next level. These are my disclosures. So, as was mentioned earlier, myeloma in 2019, the standard of care for precursor stages is MGUS, or smoldering multiple myeloma, is observation. At some point, patients develop active or symptomatic multiple myeloma, at which time we begin treatment, usually with induction therapy with a PI-IMiD-based combination, followed by consolidation with high-dose chemotherapy and autologous stem cell transplantation. And then we treat with maintenance therapy until progression. And hopefully the remission lasts for many years with this approach, but unfortunately, as we know, invariably all patients with multiple myeloma ultimately relapse at some point. And then we're left with various combinations of treatments with monoclonal antibodies, proteasome inhibitors, IMiDs, and/or alkylators. And we usually treat patients continuously with shorter durations of remission after each relapse until ultimately the patients succumb to their disease, unfortunately. So, as was mentioned earlier, that we've had a number of advances in the treatment of multiple myeloma over the last 15 to 20 years, which have changed the natural history and landscape of the disease, leading to longer durations of remission, but also leading to overall survival prolongation, with introductions of treatments such as bortezomib, lenalidomide, and thalidomide in the early 2000s, later with pomalidomide and carfilzomib, more recently penobinostat, ixazomib, elotuzumab, and daratumumab, and most recently, at least in the United States, selinexor, an XPO1 inhibitor, was approved by the Food and Drug Administration in July of 2019. But we focus a lot on the treatments of multiple myeloma that have changed the landscape and the natural history of disease, but I think also we need to focus on the evolving diagnostic landscape. So we have a number of new tools that we can now better interrogate disease biology. So we are left initially with karyotyping, and then we perform FISH analysis, later gene expression profiling, bulk DNA, RNA sequencing, but now with the advent of single-cell sequencing, we're really able to determine, hopefully, the genetics and the genetic heterogeneity of multiple myeloma much better. And this has led to, hopefully, refined risk stratification for multiple myeloma, novel therapeutic targets. We can identify, hopefully, biomarkers of treatment response, but also mechanisms of treatment failure. But it's not just these genomic tools that we can utilize, but also we have much better ways of hopefully evaluating myeloma disease detection. And we were originally left with things, more biochemical parameters, such as serum protein electrophoresis. But now with the introduction of flow cytometry technology, and more recently next-generation sequencing, we're able to detect residual myeloma disease or minimal residual disease at a highly sensitive level, to level of 10 to the minus 6. But also, just as importantly, I think that imaging advances also play a very important role. We know that bone marrow biopsies for evaluation of MRD are also limited by sampling error, and so we need to rely on things like CT, whole body PET CTs, and whole body MRIs, hopefully to detect residual disease. So for smoldering multiple myeloma, our standard approach is for low-risk smoldering multiple myeloma is observation. And for high-risk smoldering multiple myeloma, our preference is either observation or a clinical trial. And we use various risk stratification models, such as the Mayo 2220 criteria that was presented at ASCO this year, the Pathema criteria, the SWOG criteria to help risk stratify such patients. I know that there's data actually from 2 randomized trials now showing the improvement of progression-free survival, and 1 trial showing improvement of overall survival with early treatment of high-risk smoldering multiple myeloma with either lenalidomide or lenalidomide and dexamethasone. I would say this is, as you know, a very controversial area in multiple myeloma. I would say our approaches are still to observe patients with high-risk smoldering multiple myeloma, although this is potentially an option to consider based on the randomized data. But there are a number of sort of unanswered or current questions we need to address in the smoldering multiple myeloma space. And I think the big question is, who do we actually intervene on? And we really need better smoldering multiple myeloma risk stratification models that incorporate disease biology. And so particularly the Mayo 2220 criteria and the Pathema criteria really look at biochemical parameters for risk stratification, and so really need to incorporate risk stratification models that look at disease biology. But also it's important to also incorporate disease kinetics, and so many of these risk stratification models look at a single time point, a single snapshot of a smoldering multiple myeloma patients. But we know that a patient who's had smoldering multiple myeloma for 2 years with no progression of their M protein are probably going to be at lower risk than those who are advancing quite rapidly, and so that's something else that we need to address as well. And the next question is, what do we intervene with? And so there's 2 different sort of schools of thought or approaches. One approach is the curative strategies highlighted by the CAESAR trial using KRD followed by high-dose chemotherapy and KRD consolidation, or the ASCENT trial, which is looking at daratumumab, KRD, treatment for high-risk smoldering multiple myeloma. And there's also more prevention strategies using either single agents or 2 agents for treatment of high-risk smoldering multiple myeloma to hopefully prevent or delay the progression to overt multiple myeloma. I just wanted to highlight one sort of clinical trial we recently reported at MD Anderson with an anti-PD-1 antibody, pembrolizumab. As you know, pembrolizumab has not shown much efficacy, particularly as a single agent relapse refractory multiple myeloma, and the pembrolizumab combination studies were also shut down, at least by the regulatory agencies, due to increased risk of death. This study was actually designed prior to the issues with pembrolizumab and combination studies. And so this study looked at pembrolizumab basically dosed every 21 days for 8 cycles total, and the option to continue for up to cycle 24 if there is clinical benefit. So 13 patients were treated on this study with very, very sort of modest benefit. Only 1 patient achieved a response. The overall response rate was 8%. But it's very interesting because the 1 patient that did respond actually achieved a stringent complete response after just 3 doses of pembrolizumab. And this patient had high-risk gene expression profile and signature deletion 17p and 1q21. And at the time that this paper was reported by my colleague, Dr. Manasank, this patient remained in remission 27 months after 3 doses of pembrolizumab in a MRD negative stringent CR. So I think this is proof of concept that one size doesn't fit all. So as I mentioned earlier, there's curative approaches and there's also prevention approaches. And again, we need to tailor treatment based on disease biology of the individual patient. And so again, this sort of highlights some of the correlative work that was done on this 1 patient with a stringent CR. And basically, what was found was that there was increased expression of PD-1 in this extraordinary responder. There's a decreased expression of some of the inhibitory receptors, just LAG3, TIM3, and BTLA. And there's an increased interferon gamma signature in the patient that did respond compared to those that didn't. So this kind of gave a signal of maybe some way that we can try to identify the patients that may or may not respond. For newly diagnosed multiple myeloma induction therapy, our standard approach for transplant-eligible patients is to administer a PI-IMiD combination. And so the standard of care in the majority of offices in the United States is to do VRD. I would say that in MD Anderson, we do favor KRD or carfilzomib, lenalidomide, and dexamethasone as our go-to frontline regimen. I think mainly because of the increased potency of carfilzomib, but also the decreased risk of peripheral neuropathy. For transplant-ineligible patients, I divide these patients into 2 different categories: the fit transplant-ineligible, in which options such as VRD based on the SWOG 0 777 data is a possibility, or DRD from the Maya data. And then for frail patients, then a doublet regimen such as RD would be appropriate. So what are the current unanswered questions for newly diagnosed myeloma induction therapy? So as I mentioned earlier, we really need to do a better job of refining risk stratification beyond conventional high-risk FISH markers, mutations. We all know that P3 mutations are bad in most cancers, including multiple myeloma gene expression profiling. There's been work recently looking at double hit or triple hit myeloma, and what was reported at the Emory group of looking at IGL or IGL-MYC translocations, which may also play an important role in defining IMiD resistance. Although we do favor carfilzomib-based regimens at MD Anderson, there is still the unanswered question in a randomized phase 3 trial, and so the endurance trial is ongoing for newly diagnosed patients of KRD versus VRD, and we're awaiting the readout. And then I think finally the incorporation of potentially monoclonal antibodies for newly diagnosed patients or quadruplet regimens with anti-CD38, PI, and IMiDs. And so should we do this approach in all patients? Should we do it in a risk-adapted approach? And what's the impact of using a frontline anti-CD38 as part of induction therapy for subsequent treatment in the relapse refractory setting? So this is data from the Cassiopeia study, which is a randomized phase 3 study looking at daratumumab, bortezomib, thalidomide, dexamethasone versus VTD, which showed an improvement to progression-free survival and a trend towards improvement to overall survival. And also daratumumab, bortezomib, lenalidomide, dexamethasone versus VRD was reported at the IMW meeting a couple weeks ago by Peter Voorhees, which showed improvement of the overall response rate, 99% versus 91%, and more importantly, increased depth of response. So almost 91% of patients achieved a VGPR with dara-VRD combinations. It was interesting, though, that when they looked at the subgroup analysis, patients who had standard risk multiple myeloma actually seemed to derive the most benefit from frontline daratumumab treatment compared to high risk. So the question is, do we just use the daratumumab-based quadruplets for standard risk and reserve, for high risk do the standard, KRD triplets? So that's an unknown, an unanswered question at this point. What about consolidation? So for newly diagnosed myeloma patients that are transplant eligible, we do proceed with high-dose chemotherapy and autologous stem cell transplantation. For our standard risk patients, we do standard of care melphalan 200. For high-risk patients, we've been doing busulfan melphalan conditioning regimen. This is based on data from Dr. Bashir and Dr. Qualzovash from our group, published in Lancet Hematology actually earlier this year, which showed improvement of 20-month improvement PFS with the combination of busulfan and melphalan conditioning regimen, although this was at the cost of more toxicity. And so we reserve the busulfan-melphalan combination for high-risk patients. And I think the, current questions that we need to answer or address is that, do we need upfront stem cell transplantation with some of the novel triplet and quadruple induction regimens that we are now employing? So at least based on the IFM 2009 data, with VRD induction therapy, there was still an improvement of PFS by 14 months with upfront stem cell transplant versus delayed stem cell transplant. And I couldn't give a talk about this without mentioning the Forte study with KRD induction. And at least the 18-month relapse-free survival seemed to favor upfront stem cell transplant with high-risk multiple myeloma. And we do need longer follow-up to assess the PFS in the standard risk patients as well. And another question would be, do we potentially employ a response-adapted approach for upfront versus delayed stem cell transplant based on MRD status? And so there is some data from the the IFM 2009 study that potentially patients who achieve MRD negativity may have just as good of a PFS for those who, whether or not they did went up for upfront transplant or delayed stem cell transplant. The questions are when to measure MRD, the significance of a single MRD measurement, and the significance of MRD negativity in a high-risk versus standard-risk patient is because, as we know, if we achieve MRD negativity in a high-risk multiple myeloma patient, such patients potentially could relapse in 3 to 6 months very easily. In terms of maintenance therapy, our standard approach for standard-risk multiple myeloma is lenalidomide maintenance therapy. For high-risk patients, based on the HOVON data of the translocation 414, we do consider PI-based maintenance therapy. For other high-risk patients, such as deletion 17p or other multiple high-risk markers, then we would do a PI IMiD-based combination based on data from the Emory group. And we typically treat until disease progression. And so current questions in terms of maintenance therapy would be, what is the optimal duration of maintenance therapy? We treat until progression because we had no data otherwise, but now with better ways of detecting residual disease, do we potentially stop treatment in some of these patients at achieve a sustained MRD negativity. There's ongoing studies such as the SWOG dramatic study that will look to address this. And is a bone marrow evaluation sufficient for MRD testing to make treatment decisions? And so I think there's an important role for surveillance using imaging as well, which will be a talk later on today, looking at whole body MRI and PET CTs, and also potentially looking at peripheral blood MRD-based testing as well. So such testing right now seems to have less sensitivity than bone marrow aspirations for MRD testing. But if we were able to improve upon this technology, this would enable more frequent monitoring and reduce sampling error. And finally, for relapsed refractory myeloma, as you know, and as Claudia went over, there's a number of different treatment options for relapsed refractory myeloma. Choice of therapy depends on previous therapies, duration of responses, nature of the relapse, whether it's biochemical or clinical. And also you need to think about the patient, the comorbidities and their drug toxicities. I think pentarefractory multiple myeloma is a significant unmet need, very poor prognosis, median overall survival less than 6 months in a recently reported study. And optimal sequence strategies are unknown still in relapse refractory setting of, as you see, there's many different options, and which options do we consider first before later employment. And finally, I just want to close with this table of new treatments down the pipeline. So there are a number of treatments for relapse refractory multiple myeloma that have shown promise in clinical trials, including antibody drug conjugates. The one in furthest along clinical development is belantamab mafodotin, which is a BCMA ADC, bispecific T-cell engagers, BCMA chimeric T-cell, and with BB2121, which was recently published in New England Journal of Medicine, and the Cereblon E3 ligase modulator, or CELMoDs, which showed a very impressive 35% overall response rates in pomalidomide and lenalidomide refractory patients. So finally, I'd like to close with the slide of what myeloma may look like in 2029 if we start to address, hopefully, these questions that we as a myeloma community will hopefully to tackle in the next decade. So I hope, and my prediction is that, for MGUS and smoldering multiple myeloma, we will observe these patients. The myeloma will be defined not based on biochemical parameters or symptoms, but based on biology. So we'll say a patient, if they have smoldering myeloma, but they have the biological features through genomic interrogation, then we would go ahead and treat them as myeloma. And treatment would potentially involve induction therapy with daratumumab, PI, and IMiD combination, potentially, fourth or fifth generation IMiD. Consolidation with potentially with a multi-antigen CAR T-cell or bispecific T-cell engager. And maintenance we would employ for a fixed duration until we achieve sustained MRD negativity. Invariably, unfortunately, probably with these advanced approaches, we'll have patients that still relapse and unfortunately succumb to their myeloma. My hope is that we'll actually be curing a subset of these patients with some of these novel strategies, novel approaches for the treatment of multiple myeloma, in which patients, again, will be treated with optimal frontline therapy for a fixed duration with hopefully a plateau and long-term remission. With that, I'll close and happy to answer any questions.
Thank you, Hans. At first, I consider amazing the data of Griffin study. 99% of overall response rate is something that we could never imagine in multiple myeloma. In Europe and also in Italy, in our institute in IRST, we have AMN 17 is daratumumab, bortezomib, lenalidomide, dexamethasone. We are having excellent results. So we hope that maybe, I think you agree, this is the near future frontline induction treatment. Another thing is nice that we can, your open question is pentarefractory patients. I want to ask to you, what is, in your opinion, the major limitation in approved regimen that we have in Italy and in Europe, and in which phase? What do you think is the phase of disease in which we could do more with the new approval?
So is it which treatments could be potentially be most beneficial in the pentarefractory setting?
In Europe, in our approaches, what do you think? KRD in front line, which is the treatment we need for our patients as soon as possible?
I see. Yeah, I think that treating with a PI IMiD-based combination, but potentially instead of doing thalidomide, doing lenalidomide, I think would potentially be an option. And I think also early incorporation of potentially monoclonal antibodies, so daratumumab, at least by second-line therapy, and then because the data looks so good, potentially in front-line setting, I think is going to be the approach of the future.
And what about CAR T?
So I think CAR T-cell therapy is very exciting. I think we're just hit the tip of the iceberg in terms of the promise of potential CAR T-cell therapy, the first-generation therapies being reported. I think it's been a little bit disappointing that we're still not seeing a plateau in the progression-free survival curve, so it does not seem curative, with a median PFS of about 12 months or so. But I think that these are highly treatment refractory patients, so 12 months PFS in such patients is very good. And hopefully maybe by introducing CAR T-cell therapy early on, potentially either at first relapse or even as part of consolidation after induction therapy, when a patient has a more of an intact immune system, could lead to better efficacy of the CAR T-cell therapies.
Thank you, perfect. Questions from the audience? If we don't have a question, I thank Hans Lee, and I introduce Carolina Terragna, which is one of the most expert of biology of multiple myeloma in Italy, and this talk is about biology of multiple myeloma, smoldering multiple myeloma, and MGUS. Thank you, Carolina.
Thank you. So, good afternoon. So I will talk about the biology of multiple myeloma. So the multiple myeloma multi-step progression is a multi-step process which may have started even decades before the first onset of the clinical symptoms, a moment which distinguish the conventionally called clinical and preclinical phase of multiple myeloma. This process is quite easily described by the clonal evolution theory. This theory applies knowledges of species evolution, ecology, and population genetics to understand how tumor respond to selective pressure. In fact, tumor cells are subjected to selective pressure within the microenvironment, including the immune system, the therapy, the pH gradient, the nutrient constraints, and geographical boundaries. And this selective pressure actually shape the clonal evolution trajectories and the clonal dynamics. The basis of this theory resides in the fact that multiple myeloma is a complex disease system, as we recently learned in Catania. And the basis of that is that multiple myeloma is has a very high heterogeneity in the different layer of heterogeneity. We can observe an intratumor heterogeneity, an intertumor heterogeneity, and also the heterogeneity may be in time and also in space. So we can say that each patient has its own private genomic profile, and that when we look at the genomic profile on any given patient, we should always remember that by one side this might be the results of a previous evolutive process which might have occurred within years, and that this profile might change in the future due to the selective pressure of therapy that we are going to offer to the patients. This is very important because what we have always considered a static and homogeneous target for therapy is actually quite heterogeneous and continuously changing throughout the disease course. So we should take account of this type of theory when we talk about the hot topics of multiple myeloma biology. That is the monitoring of the disease dynamics, and in particularly the importance of reaching MRD negativity. The definition of the high-risk disease, which is very important to set up the risk-adapted therapeutic strategies, and also when we try to identify among patients with the smoldering myeloma those with the highest risk of evolving to multiple myeloma in order to find possibly progression markers of the disease. The monitoring of minimal residual disease is experiencing a renewed interest since the introduction of the new drugs, because the depth of response is very high now, and we need very high throughput methods such as next generation flow or next generation sequencing in order to be able to detect disease under the detection limit of the conventional methods. The objective is to stratify patients according to the presence of MRD with a sensitivity of 10 to minus 6. Because it has been frequently shown that MRD negativity with so high sensitivity identify a subgroup of patients with the highest performance during therapy. Nevertheless, we know that patients with multiple myeloma tend to experience disease recurrence. So the biological question is, why do multiple myeloma patients still relapse? And also, given the high level of heterogeneity of patients, would a single bone marrow aspirate be representative of the whole disease? One of the most intriguing theory which can explain this kind of behavior is the hypothesis that the complete response, that is the reduction of the tumor burden up to undetectable level, by creating a genetic bottleneck, allows the expansion of the branching of clones which derive from the very few residual cells after therapy. Since this branching of clones require a lot of times, the progression-free survival of patients with branching evolution is often longer than that of patients with partial response, where any bottleneck is present and where clones tend to reduce and to represent the relapse almost identical as compared to diagnosis. So we may say that in the first group of patients, few dormant new clones which resist to the genetic bottleneck are those who will allow the relapse of patients with high-risk disease. And this underlines the importance to know very well the mechanism of resistance of drugs that we are employing, and also to monitor very well the disease through the disease course, not only by measuring the disease burden, but also by analyzing the quality of the disease. This is true also when we look at the progression from smoldering myeloma to multiple myeloma. There are several data now showing that we can observe different evolution trajectories of the genome between these two disease phases. We can observe a static trajectory typical of patients where the genomic background doesn't change between smoldering and multiple myeloma. And also we can observe spontaneous evolution in those cases where some alterations emerge or are resolved in the comparison between smoldering and multiple myeloma. It is important to note that while static evolution is very quick and often patients evolve very quick, the spontaneous evolution is much slower. And this is because this branching of clones require much more time to happen. So again, this is important because First of all, because even in the absence of therapeutic selective pressure, the genomic might change. And also it is important because the genomic background that we can observe in multiple myeloma is already present at the stage of smoldering myeloma. Therefore, driver events may be already present at the stage of smoldering myeloma. We also observed similar trajectories in a cohort of patients that we analyzed by comparison samples as collected in 2 disease phases under treatment, that is, at diagnosis and at first relapse. Actually, we observed 2 main evolution trajectories. One linear trajectory where we observed only the emersion of new clones, and we think that the therapy positively selected these clones, as you can see here. You can see that we do not have this clone at diagnosis, and this clone emerged at relapse. And you can see here that these dots represent this clone which emerged at relapse. And also, we observe a different kind of evolution trajectory, this branching evolution trajectory, where both kinds of evolutive pressure are present, positive and negative. That is, that we can observe clones which are positively selected at the relapse, and also clones which were present at diagnosis, but that are resolved at relapse. And you can see here these dots representing this situation. So by stratifying patients according to these 2 kinds of selection, we have a subgroup of patients who experienced only positive selection, and a subgroup of patients who experienced also a negative selection. And you can see here the green dots represent patients who obtain a good quality of response. You can see that most patients achieving a good quality of response stratify with patients with branching evolution. So we can interpret this data by saying that the different block of therapy which compone the multiple myeloma first line of therapy, by reducing the bulk of the disease, also perform some bottleneck, and that cells that are able to survive to this bottleneck are those who may be responsible of the clinical relapse. So we can conclude that today we know that the genomic landscape of multiple myeloma, which has been thoroughly explored, is heterogeneous, and we cannot anymore ignore this fact. If we would like to see in the future, we need to design therapeutic strategies which adapt to these disease dynamics, and the aim will be to prevent or bypass this clonal escape and the disease recurrence. And before concluding, I would like to thank the group in Bologna working with me and you for your attention.
Thank you, Carolina. Fantastic talk. When do you think will be the era of biologic-driven approach in multiple myeloma in real-life setting?
In the real life, we are using FISH to stratify patients. So we are looking just to few alterations, and we assign to this alteration the role of being high risk or low risk or intermediate risk. But it's not enough. We know now that the genomic background can modify the risk of this alteration. So we first needed to upgrade our method to analyze more in a more wide way the genome, and then probably we can think at the risk-adapted strategies.
Yeah, at the moment we have only prognostic information. So
right.
Not risk. Yeah, thank you. Question from the audience? So I am really happy. It's a pleasure for me to introduce Elena Zamagni. Which will speak about the importance of imaging in multiple myeloma in the era of novel agents. Thank you, Elena.
Thank you, Claudio. Good afternoon to everyone. So multiple myeloma is a plasma cell neoplasm that primarily is involving in bones. And this is happening in nearly all the patients, either at diagnosis or during the course of the disease. And we know that our patients are suffering from this, sometimes with pathological fractures and spinal cord compression, and that the persistence of bone lesions contributes to the frailty of patient. The bone disease in myeloma is due to an uncoupled bone remodeling with an increased activity of the osteoclast and a reduced activity of the osteoblasts. So it is clear that imaging plays a very important role in plasma cell dyscrasias, and this is true both in the early phases and also in active disease. In early phases, we need to have what? We need to exclude the presence of bone disease, and we need to predict the risk of progression to the active phase. While in the active phase, we need first to assess the presence of bone disease, that is to say a sign of end organ damage needing the start of a new line of treatment, eventually assessing sites of extramedullary disease. We also need to assess bone stability. We need as well to assess the tumor burden for prognostic reasons, and last but not least, we need to assess nowadays the response to therapy. Since the criteria for the diagnosis of multiple myeloma were updated in 2014, the novel imaging techniques represent now the mainstay for the definition of myeloma bone disease. And this is true because they demonstrated to be highly sensitive, more sensitive when compared to whole body X-ray, that was the traditional technique that was used, that is often underestimating bone disease. We usually classify imaging techniques in morphological that are assessing bone destruction, so what has already been done, and this is the whole body low-dose CT and the CT part of PET-CT, or in functional techniques that are assessing either bone marrow infiltration, and this is the case for MRI, or disease metabolism, and this is the case for PET. Nowadays, we also have new software for MRI, like dynamic contrast enhanced, which is evaluating differences in perfusion, or diffusion-weighted imaging that is evaluating difference in cellular density and can be quantified by this coefficient named ADC. So we can use these techniques to stage or restage in the relapse phases the disease, but also to evaluate response to therapy. So two important studies clearly demonstrated that patients suspected to have smoldering myeloma with whole body X-ray, in 13 to 25% of the cases would have misdiagnosed when using more sensitive techniques like whole body low-dose CT or PET-CT. So this is the reason why nowadays whole body X-ray is clearly considered to underestimate the disease, as well as the presence of more than one focal lesion gives 80% of risk of progression to active myeloma. So for this reason, nowadays, the definition of myeloma bone disease is the subsequent, so the clear evidence of one or more sites of osteolytic lesions with one of the novel imaging techniques, and the skeletal radiography is only dedicated for centers that cannot go for anything else, but also the presence of early bone marrow infiltration with more than one focal lesions. On the contrary, osteoporosis, the per se not attributable to myeloma, is not sufficient anymore to define bone disease. Of course, we have to be careful because the more a technique is sensitive, the more, of course, there can be false positive results. So when there is a doubt lesion, the International Myeloma Working Group, I will show you very soon, is recommending an alternating follow-up with different imaging techniques or to biopsy the lesion. So what can we use for staging and restaging? We may go for whole body low-dose CT, which is a relatively simple and easy and cheap technique that is identifying both lytic lesions and also extraosseous lesions and can be the guide for biopsy. Usually CT cannot see bone marrow infiltration, but in the long bones, where usually in the adults the bone marrow is fatty, and so you may see some bone marrow infiltration also with this technique. The second technique that you can use is PET-CT. That is a dual technique that merges together the morphological part, as I said before, looking at lytic lesion, with the metabolic part, looking at the tumor burden. Approximately 80 to 85% of the patients at diagnosis are positive with FDG PET-CT, which is also the gold standard to identify eventual extramedullary lesions. And we know that this is very important because the prognosis of this patient is particularly dismal also in the novel agent era. We know that PET-CT in many studies demonstrated to have a prognostic relevance in terms of number, size of focal lesions, and SUV max. Or last, we can use magnetic resonance that displays a clear pattern in myeloma, so it's easy to identify myeloma, but for the diffuse involvement. But in this case, the DVI protocol came to help us, and so now it's easy also to identify a diffuse involvement. But we have to know that this technique is not looking at the same thing when compared to CT, because it's looking at bone marrow infiltration, and it's looking at the infiltration before a damage and the bone has been destroyed. So we have to be aware that we are not looking exactly at the same things. MRI is positive in 85 to 90% of the patients at diagnosis, and also MRI focal lesion displayed a prognostic relevance. This technique, we know that is also the gold standard to differentiate between benign and malignant fractures, or, as I said before, osteoporosis. The International Myeloma Working Group is highlighting the importance of a correct reporting and standardization of this technique. We have to speak all the same language if we want to use imaging techniques to evaluate response to therapy and for prognosis. The work has been done for whole body low-dose CT and is in progress for MRI and FDG PET-CT. So what should we use, you may ask me? It's not easy to make recommendation because each country has different expertise, resources, guidelines. However, we tried within the International Myeloma Working Group to make a sort of recommendation. It was not easy. It was a very hard job because, for example, between US and Europe, the situation was completely different, but we thought that it was important to give at least a basis to people and also for administrative reasons. So whole body low-dose CT, as you can see, is considered the minimum requirement. So first go for a whole body low-dose CT. If it's positive, the job is done. If it's negative, you may go for an MRI, possibly whole body, if you can't, axial. If it's positive, the job is done. The patient has an active myeloma and you may treat him. If it's negative, or if it's doubt, or if there is one focal lesion, the suggestion is to alternate every 6 months whole body MRI and CT, because as I said before, they are looking at different things, so you may catch one point or another, because of course neither of these techniques is perfect. But in 2016, the International Myeloma Working Group also introduced the concept of imaging MRD, while introducing for the first time in myeloma the definition of minimal residual disease. So why they thought that it was important to add to the bone marrow evaluation with NGS or flow cytometry also imaging techniques, because it was clearly demonstrated mainly by the Little Rock group, but also by many other groups, that in addition to the clonal temporal heterogeneity that Carolina clearly showed to us, in myeloma you can also face spatial heterogeneity. So the patient can have a different gene expression profile in the bone marrow and in the focal lesion. And this is more true when focal lesions are big, and is more true when patients have either para or extramedullary disease or in the relapse phases. So in these phases, for sure, it's important to check the bone marrow and outside the bone marrow. The technique that was used most to evaluate metabolic response to therapy is PET-CT. Several independent, mainly prospective studies demonstrated that nearly 80% of the patients after first-line treatment are achieving a complete FDG suppression, and their prognosis is particularly better, both in terms of progression-free and overall survival. However, as you can see, 25 to 30% of the patients, even in complete remission, may maintain a PET positivity after therapy. So what is happening when you are achieving minimal residual disease in the bone marrow? I think that these 3 independent, 2 retrospective and 1 prospective studies clearly show that there is complementarity between bone marrow and imaging, because as you can see, there can be a discrepancy ranging from 38 to 50% in the patient between the bone marrow and the imaging. And in particular, as you can see, the data is relatively stable. 12 to 16% of the patient may be negative at the level of flow cytometry 10 to the minus 4 or 10 to the minus 5, and positive in the imaging. So really the 2 techniques are complementary, and the prognosis of patient either negative is the best, while of course if they are either positive is the worst, and one of the 2 positive is in the middle. However, PET is not perfect, because there is a small percentage but present of patients, approximately 10%, that are negative since the beginning, because they are not trapping the FDG in the cell, because they lack the enzyme that is trapping the FDG in the cell. So for sure, in this patient, we may not use FDG PET to evaluate the response to therapy. So we may use a different biomarker, and we know that methionine and choline may be more sensitive. However, they should be produced on site. They are more expensive and not standardized at the moment. Also, in the last year, there were some studies, first in murine models, and at the International Myeloma Working Group in Boston, it was also presented the first in-human study by the group of Ola Landgren using daratumumab as a radiolabel tracer. So you may use MRI to evaluate response to therapy. There is no room for standard MRI because the response is late, and often you can have false positive results. So you have to use the new functional MRI, dynamic contrast enhanced or DVI. And there has been several studies demonstrating clearly that the ADC is changing. Normally the ADC is low because in the adults we have a fatty bone marrow, so low diffusivity of water molecules. When the focal lesions are responding at the beginning, the ADC is going up because of the necrosis and then is going down. This is not true for the diffuse involvement that is immediately decreasing, while of course patients not responding are remaining unchanged. So it's not so easy to evaluate this, and a study from the Little Rock group clearly showed that if you are not well understanding the residual focal lesion, you are maybe mistaken, because as you can see, only restricted, well-evaluated focal lesion has a prognostic relevance. So what should we use, PET or DVI? We lack prospective study. We only have this very small retrospective comparison showing that maybe DVI MRI is more sensitive. As you can see, 18% versus 3% of the patients are positive, but we lack prospective comparison. So nowadays, the recommendation by International Myeloma Working Group is to use PET-CT after therapy. If it's negative, you stop there, you not go on with PET-CT every year. If it's positive, you have to do a follow-up with an annual PET-CT. So we still lack some points to implement the use of imaging after therapy. The first is the prospective comparison of this technique and to go on with the standardization of the technique. But in particular, we have to use imaging techniques in our clinical trial. And this is just an example that I asked to the Nordic group. They planned this protocol using a PET evaluation after therapy and stratifying patients. Those negative are going on with maintenance. Those positive are receiving additional treatment prior to maintenance. So to conclude, I showed you that we have several validated points in the use of imaging in multiple myeloma. The first one is that we have, when possible, to use novel imaging techniques, and the minimal requirement is whole body low-dose CT. By now, the preferred technique after therapy is PET-CT, that clearly demonstrated to be complementary to bone marrow techniques. We still have some open issues that are ongoing and under investigation in clinical trials, and this will, of course, improve the use of these very good tools for the management of multiple myeloma. Thank you.
Thank you for that wonderful talk. I had a couple of questions, actually. So one question is, If you have a patient in CR on, let's say, maintenance lenalidomide, and they've been in CR for several years, how often do you do surveillance imaging on such patients, and what method do you use typically?
We are not doing this anymore, as I showed. We are just doing once before the start of maintenance. If the imaging is negative and the patient is not progressing, data are showing that the probability of progression only in imaging is very, very low, so it's not worthy. If the imaging is positive, I'm following up the patient, possibly with the same technique, of course. We are using PET-CT in Bologna, but other groups are more experienced with MRI. It's important to be well experienced, of course.
And then the other question is, so in the United States, we would love to do PET-CTs on all our patients, but actually we have a lot of challenges in getting sometimes third-party payers, insurance companies to actually pay for the PETs. And so hopefully the new updated imaging guidelines for the IMWG is going to help with that. Do you face similar challenges as well in terms of getting PET-CTs?
That's why, in fact, I told that it was a hard job to reach an agreement, but I think that these guidelines we did mainly for you, US guy, because you need this to be reimbursed.
Right.
You know, in Europe, the system is different, and we are more free, at least for this thing.
Yeah, thank you.
In NIRS, we are starting a clinical trial comparing PET-CT versus PET-CT plus MRI since frontline setting. Maybe the combination of two imaging techniques will be the best choice. What do you think?
Yes, the problem is the cost, of course.
Yeah.
So you may not recommend this
No,
all
starting
over.
from a clinical
However,
trial.
to have a prospective comparison is very important. You're using DVI or normal MRI? DVI.
Thank you. Questions from audience? Okay, if not a question, we thank Elena.
So, yeah, now I'll introduce Dr. Vittoria Montefusco, who will be talking about older and newer generations of drugs and new combinations of the PI, IMiDs, monoclonal antibodies, including carfilzomib, ixazomib, pomalidomide, daratumumab, elotuzumab, and beyond.
Okay, thank you. I would like to thank Giovanni and Claudio for inviting me to this beautiful meeting, and I start saying that if you need a guidance for the use of new drugs, well, we have this guidance. We have the ESMO guidelines that tell us a few things. Basically, they stratify patients according for the type of therapy that those patients has received in the first line. An IMiD-based first line or a PI-based first line. And the basic concept of these guidelines is represented by the fact that patients change the type of drug, the mechanism of killing from the first to the second line. So they go from an IMiD-based to a PI-based, doublet or triplet, and vice versa. In case of PI-based first line, they receive an IMiD-based second line, doublet or triplet. The second key point from these guidelines is that you have to to do the maximum efforts in the treatment of the disease at first relapse when there is a reasonable chemosensitive. And if we look at the clinical practice also in the years before the release of these guidelines, we can see that European hematologist in effect has basically always used this approach. This retrospective study from more than 12,000 European patients tell us that basically patients who received an IMiD-based, in this case thalidomide, first line, mainly receive a proteasome inhibitor-based second line, and vice versa. Those who have received bortezomib in the first line mainly receive lenalidomide, which means an IMiD in the second line. So this is this reflects the guidelines reflects our cultural approach, and Luckily, nowadays we have a lot of options to treat in the clinical practice our patients. We can divide the regimens in two categories: the IMID-based regimens, which can be based on lenalidomide or pomalidomide, and the PI-based regimens. And luckily, nowadays we have several types of proteasome inhibitors: bortezomib, carfilzomib, and ixazomib. But how can we choose the right therapy for our patients? Basically, we don't have predictive factors. We don't have the Philadelphia chromosome, such as in acute and chronic leukemias. So we have to find some help elsewhere. We can say probably that translocation 1114 can be a sort of predictive factor for venetoclax treatment, but this is really a niche in this situation. So we can base our choice on the results from fish. In particular, we have problem in treating high-risk fish patients. And if we have a look to the efficacy of the new drugs or the new combination respect their control arm, considering the registrative trials, you can see that basically all the new drugs, carfilzomib-based regimens, XRD with particularly interesting hazard risk 0.45, ELO-RD are effective in this setting. And a particular focus can be done for pomalidomide and deletion 17p. A small but very interesting French trial has shown that patients with deletion 17p benefit in particular for treatment with pomalidomide. So this can be a hint for the treatment of these patients. So beside the high-risk fish, we can identify patients with other high-risk features. And I think that you agree with me that elevated LDH, presence of extraosseous disease, a quick increase in M component represent markers of aggressive disease. However, we don't find this information usually in the subgroup analysis of prospective clinical trials. So we have to rely to identify those patients on other features such as ISS 2 or 3, refractoriness either to IMiDs or proteasome inhibitors, and the number of previous lines. And if we analyze data according to this approach, we can see that again new therapies are particularly effective also in the setting of high-risk patients. This is true for carfilzomib-based regimen, for XRD, for ELO-RD, and for DARA-based regimens. And when we have to decide a new therapy, we based our decision, of course, on the results of progression-free survival from clinical trials, but also from other endpoints. And another important endpoint that has been already mentioned by the previous speaker is minimal residual disease. Overall survival is a big endpoint, but is quite elusive for in this setting. And if we consider minimal residual disease, we can see that this parameter is quite reliable in the fact that it's independent from the treatment type. So as you can see, you see patients treated with different therapies, and those who achieve an MRD negativity do similarly, irrespective on the treatment they received. And more important is the maintenance of the MRD negative status, because you can see on the left patients who have 1 or 2 points of MRD negativity, and in the right panel patients who have at least 2 points of MRD negativity maintained for at least 1 year, and you can see that the curve is about 100%. So MRD negativity is a new important endpoint in the selection of our therapies, in the interpretation of the clinical trial, and we now know that this parameter is not predictive only in terms of progression-free survival, but also for overall survival. So we can quickly review the efficacy of the different combinations, and I would like to point out that DARA-based regimens are particularly important for the as a risk, which is in the range of 0.3, 0.4. But we have other interesting drugs, carfilzomib, which can be used for induction before salvage treatment. We have ixazomib, which can allow us a total oral triplet. Another point to take in consideration is the fact that patients experience shorter responses in more advanced lines of therapy, and this is not by chance. Carolina has nicely shown us that myeloma evolution is an important driver of chemorefractoriness, and so the earlier we treat our patients, the higher is the possibility that the patient has a more chemosensitive disease, and this is the reason by the guidelines, and also I think all of us in the clinical practice choose the best therapy, the best combination in the first, use the best combination in the first relapse. And as you can see, this effect is particularly evident in this sub-analysis of the Pollux trial. You can see in the left panel patients who have been enrolled and treated in the first relapse, and in the right panel, patients who have been treated in second or third relapse. You can see the blue line, the DARA-VD therapy is particularly high in patients in first relapse. So we have to use early the best approaches. And then we, in our algorithm of decision, we have to consider also the presence of specific comorbidities, previous toxicity, and also the logistic, of course, is different for a patient to be treated with a total oral triplet or a triplet based on injective monoclonal antibodies. And then, last but not least, the cost, which are not the topic of my presentation, but which are a very important issue, as all of us know. And regarding toxicity, we can see at a quick glance some of the most important toxicities of the new drugs. In particular, carfilzomib, as you know, is characterized by a possible cardiotoxicity, but I have to say that an aggressive treatment of hypertension can limit the occurrence of this complication. Ixazomib has some neurotoxicity, so we have to use it carefully in patients who have a residual neurotoxicity from a first line based on proteasome inhibitors, and which means bortezomib. And it's very interesting that monoclonal antibodies has not basically any substantial additional toxicity respect to their partners. But as you have seen from the Professor Lee presentation and also Claudio presentation, all I'm saying will change rapidly, because in the next few years the most part of our patients will probably receive daratumumab in the first line, both transplant eligible and transplant ineligible patients. So this will change our therapeutical approach for the relapsed patients. We will use more pomalidomide, probably more carfilzomib in the second line, but quickly our paradigm will change, because newer immunotherapeutical approaches will arrive. We will treat patients with CAR T-cell, BiTEs, antibody drug conjugates, whatever you want, earlier, and maybe for high-risk patients, we will use them in the first line. Thank you for your attention.
Thank you, Vittorio. Fantastic talk in a really difficult topic. I have for you the same question before answered by Hans Lee. Which is, in your opinion, the most important limitation we have in Europe, and in particular in Italy, in multiple myeloma frontline relapsed refractory setting at the moment? Which do you think we need more, considering the new regimen, the near frontiers of multiple myeloma?
Well, I think that in Italy now we are quite lucky, because we have a lot of drugs and combinations that we can use, that we have to use appropriately, of course. I think that when daratumumab will be incorporated in the first line, one big problem will be in our day hospitals, because until we will not have sub-Q daratumumab, we will have big problems. I foresee, for example, that in my center we will not be able to treat with daratumumab all patients that can be candidate to this therapy. So this can be one point. A second point is represented by the fact that we want. I think that we are in extreme need of immunotherapeutical approaches, CAR T-cell and so on, because we have patients who need them, who are tetra-refractory, penta-refractory, and we have nothing for them, but unluckily we are quite behind in this setting.
I agree also with the problem of daratumumab for outpatient setting in Italy. Also for relapsed refractory setting, we are also having a problem. We needed subcutaneous administration, absolutely.
Yes,
maybe
as soon as possible.
That is the thing we need as soon as possible.
One other question is, so at first relapse in a patient who's progressing on low-dose len maintenance, what is your recommendation, your sort of go-to regimen that you would recommend at that point?
Well, if you consider, for example, a patient who was receiving lenalidomide as maintenance after autologous, I would say that this patient can receive a KD, carfilzomib, dexamethasone combination, and then go to a salvage autologous transplantation if there are stem cells, and if the progression-free survival of the previous transplant was longer than 18 months. For example, in my center, I will treat the patient in this way. And for example, in a patient, for a patient who is more advanced as age, who has received a RD in first line, I would consider DARA VD, for example. You change the mechanism of killing, or something, or yes, I say DARA VD. Also because DARA does not add particular toxicity with respect to the VD regimen.
Thank you.
Any burning questions from the audience? If you don't have, we close this first part about multiple myeloma. Thanking Hans Lee. It was, like in the previous sessions, nice the comparison between Italian reality and USA reality. And we want to introduce the co-chairs of next sessions.